introduce everyone. Good afternoon. This is Dr. John Bennett, broadcasting from Miami, Florida. Today we're going to have a regular neurosurgical TV hangout, and tonight we have a pinch hitter, Sean Orr, neurologist from Jacksonville, Florida. He's going to talk about. He's agreed to talk about stereotactic surgery in Parkinsonism. It seems like he has a background in stereotactic surgery. Maybe he could fill us in on a lot of what's going on out there. And we're also joined by a panel of distinguished panelists, and we'll go around and we'll first introduce the panel, and then we'll turn it over to Sean. So could you start, Eleonora, please?
Yes. Hello, I'm Eleonora. I'm a sixth-year medical student in Rome, Italy.
Welcome, Eleonora. And you're Suri? Could you introduce yourself, please, and tell me what you're doing? Tell us what you're doing. Hello, Suri? Can you hear me okay?
Yeah.
Could you introduce yourself, please?
Hello.
Can you hear me okay?
Yeah.
Can you introduce yourself, please? I guess not here. Okay, Simon, go ahead.
Hello, my name is Simon Downs. I'm in Tokyo, Japan. I'm a medical student and a developmental psychologist.
Welcome, Simon. Dustin?
Hi, my name is Dustin Finch. I'm in Miami, Florida, and I am a software developer.
Okay. Okay, Sean, we'll turn it over to you.
All right, great. Well, thanks, John, for the invitation, and I'm happy to be pinch hitting today. I would just start out by giving the caveat that I'm a neurologist, not a neurosurgeon, so take that perspective. My background is in interventional neurology, so I was trained to be an endovascular therapist, skilled in the use of catheters and other microscopic surgical instruments to remove blood clots from the brain and repair brain blood flow. I was also trained as a neurointensive care neurologist, taking care of the most critically ill patients with neurological diseases, and my third area of expertise is in stroke, taking care of patients with acute ischemic cerebral damage. But along the way, of course, I've been very fortunate to be exposed to some of the most amazing people in the field, and have fortunately learned a thing or two along the way about Parkinson disease, and been fortunate enough to treat a lot of wonderful patients afflicted with Parkinson's. So I think maybe just to kind of give a broad overview, since the topic is about stereotactic surgery, I think it's helpful to just take a minute to talk briefly about what Parkinson disease is, and realize that there's actually a larger spectrum of disorders that we call the Parkinsonian syndromes. So there are many things that look like Parkinson disease that are not quite. Parkinson disease is actually a degenerative disease that it largely affects the substantia nigra, which is a group of neurons in the brain stem, and deprives the brain of these dopamine projecting neurons that usually land up in the front of the brain in an area called the globus pallidus, and the substantia nigra projects to what we call a striatum, specifically actually in the basal ganglia of the brain. So Parkinson disease, being a degenerative disease, about 10% of the time is actually inheritable. We have genetic forms of Parkinson disease that are traceable through families because of genetics, and the rest seem to be for a variety of other reasons. And there have been many ideas over the years why Parkinson disease actually develops. We think that some people have a susceptibility genetically, some people have difficulty clearing out bad proteins from their brain. So there are many different ideas why Parkinson disease develops. The common theme in Parkinson disease is that there is a progressive loss of dopamine in the important parts of the brain that control the smoothness of movement. So we have in Parkinson disease what we call hard signs and soft signs. The hard signs are the obvious changes that take place in somebody's motor movements, and so we'll often see changes in facial expression, so the loss of the subtle nuanced facial movements. We call that hypomimia. We will also eventually lose motor control in the limbs, and that may start out early on as a fine tremor. Typically we think of this as a resting tremor, and so you may see a shaking of the thumb or the hand that eventually progresses to the rest of the arm, and in cases it can actually become quite severe and involve large portions of the body. Parkinson disease affects the ability to walk, as well, which is another hard sign. And then there's some what we call softer signs, and those are typically what we call autonomic changes. So it turns out that one of the first changes is the loss of the ability to swallow properly. Very early in the course of Parkinson disease, many patients will actually start to aspirate on their food because they don't swallow properly. Their voice can change, vocal inflections can be lost, and actually you can start to see cognitive changes and mood changes, personality changes, just a general flatness and a lack of engagement, which sometimes can get misinterpreted as depression or a loss of interest in life. And it can be a little frustrating, especially for a young person to be diagnosed, because it has such dramatic implications for their own well-being and such. But the good news is that Parkinson's disease is actually very amenable to therapy. So our first step in the setting of Parkinson's disease is to actually make sure that we have the right diagnosis. And again, that can be quite challenging early on. It is a clinical diagnosis, and there are some other mimics. One important mimic would be what we call normal pressure hydrocephalus, and this is a condition where the cerebral spinal fluid that bathes the brain actually can accumulate and not drain the way it normally should. And when that occurs, then Parkinsonian features can start to develop. And the good news is that there is a surgical repair for that, and some medical therapies for it as well. Often a very gratifying condition to treat, because a patient who's early on in the stage of a normal pressure hydrocephalus can act very demented, and it can be losing the ability to walk and having urinary incontinence. Treating it can reverse those effects if you get to it early enough. It is one of the more common mimics of Alzheimer's disease. There are some other Parkinsonian syndromes as well that probably are worth going into in a different talk one day, since we're having a surgical talk here today. As a neurologist, I can get pretty far off into the weeds talking about the other types of Parkinsonian lookalikes. But I think what we've discovered over the last 20 years is that surgical approaches to taking care of Parkinson's disease can be highly effective and very gratifying for the patient to experience significant improvements in both their motor fluctuations or their motor changes and their other kinds of changes as well, such as the personality changes and such that come with it. So generally speaking, there are two largely accepted groups of surgical approaches, what we call stereotactic approaches to surgery for Parkinson's disease. And in general, we think of them as opposite sides of the spectrum. So one approach would be what we call ablative therapy, where we're actually destroying brain tissue that we think is overactive and has not been suppressed properly by the dopamine circuits from the brainstem. The other approach is stimulative, and this is where we're actually implanting devices into the brain, pacemakers of the brain, if you will, and they're set at a certain frequency and inserted in a certain area of the brain, the intent of which is to increase or mimic the effect of dopamine circuits coming from the brainstem. So generally speaking, the ablative surgeries, as we've already talked a little bit this morning in our group, are aimed at the globus pallidus and the subthalamic nucleus, or even the subinsular tissue. And so these are all different technical terms, and all you really need to do is take a quick look on Google for stereotactic therapy, and you'll find that you can find these structures fairly easily. I think it's worth probably saying here that the basal ganglia, particularly the striatum, which is an accumulation of tissue deep inside the brain that governs motor movements, is a highly regulated area with many feedback loops. And some of these loops are positive feedback loops, and some of them are negative. And the idea here is that in order to attain fine motor movements and fine control, there's a need to have a very tightly yoked system that allows for instant feedback to the brain about position of limbs in space, and for things like pressure and rate of change of movement over a spatial distance. So there are several different inputs that all have to be integrated at the same time in order to accomplish a smooth motor movement. And in the basal ganglia, when these motor movements are deprived of dopamine, which is the primary modulating neurotransmitter in this region, then things start to break down. And you'll find that some of these feedback loops get exaggerated and some of them get downplayed. But the final common denominator is again, a loss of control over motor movements and an involuntary tremor that takes place. Now, when patients are started on treatment, there are a couple of schools of thought about the medical therapy, and it's important to talk about this briefly. But medical therapy basically falls into two different groups. There's the medication that replenishes dopamine, so it fills up the bucket, if you will. And then there are other medications that actually block the metabolism of dopamine, making sure that you have enough dopamine left over to function. So Sinemet and Stalevo are the common names for the medications that replace dopamine. And the active ingredient in there is levodopa. Levodopa is the medication that gets into the brain, and it's coupled with carbidopa, which acts at the level of the intestines to prevent the breakdown of dopamine through the intestinal tract. So levodopa, when it enters the brain, it enters and affects the neurons that are supposed to send dopamine to these regulatory circuits. There's a variety of other medications that actually prevent the breakdown of dopamine, and there are about 4 that we typically think of. And rather than bore you with going through all the nuances of those, it's just good for you to know that we basically make more dopamine available to the brain by preventing the breakdown of dopamine. So those are strategies that we use, and one school of thought says that it's a good idea to use the dopamine agents like Sinemet early on in the course of the disease in order to prevent some of the chronic motor debility that comes on with Parkinson. There's another school of thought that says that we should wait and use the dopamine sparing agents, the dopamine blocking, the metabolism blocking drugs first, and then only late in the course of the disease should we use the levodopa. So I think there's quite a bit of discussion back and forth in the industry about which is the better approach. Either way that you look at it, the longer the disease progresses, the more likely patients are to develop other motor movements, which we call dyskinesias, oftentimes in relation to the medication that they're taking. So dyskinesias are also uncontrollable motor movements, and as I mentioned earlier, you may have seen Michael J. Fox, who's really a wonderful person for having put himself out there and really has brought a lot of support to the study of Parkinson and treatment of Parkinson's disease. If you ever watch one of his characters on TV or in a movie, you'll see he has this chronic kind of a sinewy movement that he incorporates into his speech patterns. Those are dyskinesias. And so dyskinesias can be absolutely debilitating, and it turns out that ablative therapy, especially destruction of the subthalamic nucleus, which is a group of neurons underneath the thalamus, deep in the brain, right above the brainstem, seems to actually confer quite a bit of relief for the patients who have dyskinesia. So that's one example of how we use ablative therapy. Stimulation therapy, which essentially the technical term is deep brain stimulation, or DBS, typically is used with one of the products. Medtronic is the leader in this area. They've made their mark by having more than 100,000 patients out there with brain implants, deep brain stimulators. So we have a large group of cybernetic human beings who are much better off now because of their deep brain stimulators that are improving their movements. And so stimulation therapy is, again, at the other side of the spectrum. The idea is just by implanting a small electrode deep inside the brain, we can actually replace the signal that normally is generated by the dopamine neurons. It's a tricky process. It does involve the placement of small, what we call fiduciaries, which are essentially small screws that go into the skull and are registered on a CT scan or an MRI. And these fiduciaries allow us to create a local GPS, if you will, of the head. And using that GPS system, the surgeon can actually, in real time, track the movement of a stereotactic device through the brain tissue with a high degree of precision. In the early days of stereotactic therapy, we didn't have live placement, and it was usually a best educated guess about the direction that the device is going. So it was not nearly as precise surgery as it is today. So the technology has come quite far, and we're seeing 4th generation stereotactic sets that are coming into the market now. They are quite expensive, but when you think about the net benefit to the patient and to society and reducing disability and improving outcomes, there's quite a bit of value in actually using these devices for the larger good of humanity. So I think it's generally accepted that the cost of this equipment is well worth it. Typically, stereotactic surgery is considered an outpatient procedure these days. It's usually, in the United States, typically most patients will come in the morning and have the surgery done and be gone by later that day or at the very latest the next day. There can be some complications that take place. Infection and hemorrhage are the two that we always worry about the most. But in the right hands with somebody who's very experienced, those risks are relatively small, generally on the order of 1% or so. The risk of having a wrongful placement of the device is always there, and you know, a suboptimal outcome can occur. But generally speaking, most patients are aware that it's a possibility and are willing to go through the risk, and knowing that they're going to highly specialized centers that can handle it. So for the most part, again, infection rates and the rate of bleeding into the brain are very low, and if they do occur, they can be dealt with. Pacemakers themselves have some potential for complications. For one thing, you're bound to set off every airport metal detector that you walk through in the future. So you know, that's one side effect of having a pacemaker. The battery can run out, and that may need to get changed over time. The modern pacemakers are actually able to be hooked up through the internet now. This is opening up a whole other interesting can of worms. And this applies to cardiac pacemakers and brain pacemakers. Now, you know, a neurologist sitting remotely can actually read the pacemaker's equipment and assess it remotely. So if I had a brain pacemaker here at home, I could hook up and have a neurologist somewhere 1,000 miles away or across the other side of the world analyze the effect of my pacemaker and how it's working, which then, of course, opens up the question about what about hackers. And there has been some concern about the possibility, and it has been demonstrated in the hacking community, that these devices actually can be hacked. And so you know, could somebody inadvertently suffer a complication by having their device modulated against their will by a nefarious force? It's certainly theoretically possible. I don't know that there are any cases that have actually occurred, but it is something that gives us pause. And then ultimately, the biggest concern is loss of effect over time. So the pacemakers themselves are adjustable, and typically we use a small magnet that fits across the chest wall, and that magnet interacts with the pacemaker itself, and the doctor who's doing the programming can interrogate the pacemaker and can actually modulate the signal that's going to the brain. The benefit of that is that in real time you can actually watch the effect on the patient in your clinic and see if you make the symptoms better or worse, and as time goes on, scar tissue forms around the lead itself. You can actually see some changes that take place in the effectiveness of the device. Unfortunately, in some patients, as the disease progresses, eventually either ablative therapy or even a DBS device can lose its effectiveness. And so, you know, for this reason, you know, we think that these technologies, although they're very useful, this approach, stereotactic therapy, is very useful. It is simply just one of many strategies that we use in order to improve our patients' well-being. And really, that is a large scope of activities that we do for our patients with Parkinson disease. So we typically like to focus on the basics, which is making sure that they're getting the proper amount of diet, sleep, and exercise, that they're treating their bodies properly. There's a lot of evidence that using bicycle riding and other forms of exercise that stimulate balance, such as yoga, can actually improve outcomes. Getting the proper amounts of sleep is very important. Parkinson disease patients often will have significant insomnia, and that can be quite plaguing for them. There are some new medications that are affecting the orexin system of metabolism of the brain that seem to be improving that for Parkinson's patients, and that tends to indirectly impact symptoms in a positive way. We think that dietary changes may be helpful. There's some evidence that coffee, for example, is protective against the effects of Parkinson's disease. So there probably are other nutrient-oriented strategies that may be helpful for these folks. And then, generally speaking, in the setting of a holistic approach to taking care of a patient with Parkinson, stereotactic therapy can be widely successful and very useful. So, and we think at this time we're simply just scratching the surface when it comes to stereotactic surgery. There's an interesting company out of Israel, and I happen to have the great fortune of being somewhat involved in a consortium that's interacts with Insight Tech. You may be aware of this company. If not, I'd suggest that you take a look at it. Insight Tech has developed a novel approach to using ultrasound in order to create a non-surgical scalpel that actually can modify brain structures. And so in cases where a patient has a hard-to-reach brain tumor or an arteriovenous malformation, or even possibly in the setting of Parkinson disease, we're showing that this array of ultrasound that's highly focused and navigable under the guidance of an MRI can actually give us highly precise, very accurate modification of brain substance. And so it's a really exciting new technology that I think you're going to be hearing a lot more about in the near future. So that's probably the most up-to-date technology that you're going to see come out when we're talking about stereotactic surgery of the brain. So that's kind of it in a nutshell. John, I've just been sitting here rambling on. Any questions about that?
No, thanks a lot, Sean. That was a very good presentation for me to understand the pathophysiology of Parkinsonism and the loops and the feedbacks, etc. That I've never heard explained that way, but it's very understandable. Suri, are you there, Suri? Can you hear me? I want to ask the neurosurgeon here, unless he's on a coffee break. Well, let me just make some comments until Suri chimes in. Now, I'm not a neurosurgeon, Sean, but do you have to do a craniotomy for the deep brain implants? You have to open up the skull for that, or is that done through catheters?
Actually, you can hear me?
Yes, I can hear you now, sir. Go ahead. Go ahead, sir. Take over.
Yeah, actually, in the implant, putting implant and all, we are not going for big craniotomy and all. It's like a minimal invasive type of surgery. So in India, we are using like a small burr hole or two burr hole approach. In that, we are assessing the point like STN or globus pallidus or other centers where we are going to lesion or where we are going to put the deep brain stimulation electrode. That area we are assessing by we are marking by the navigation system, like dedicated MRI in the operation theater, or like mobile navigation system or stereotactic. We are making that lesion marking, and after that we are taking burr hole, and there is no need of big craniotomy and all, and minimal invasive like simple burr hole or simple one single hole by 2 by 1 centimeter. We are putting that up to a mark under the guidance of the fluoroscope or by the navigation system by the remapping.
So a minimally invasive, so you don't have to open the skull. You don't have to crack the skull.
There is no need to open full of the skull, because there is a fantastic navigation system which is available, and by that, like star skyline type of big navigation systems are there, which are very helpful during the operating time. And old stereotactic system like leg shell we are using previously, leg shell apparatus and all, but nowadays there is a dedicated MR in the operation theater, and other navigation systems are there which are very easy to assess the point. And other than that, there is a stereotactic dedicated album is also there, atlas is there, which is giving very correct marking like 2.1 centimeter lateral or 4.5 centimeter anterior or posterior, where is the location of the nucleus, like STN or globus pallidus from the ventricular margins and all. By that way, we are getting very nicely approached, and most of the cases we are getting very nicely placed. We are getting very nicely approached by the navigation system. So there is no need of craniotomy in this kind of surgery, because stereotactic navigation is itself a big revolution in the neurosurgery, specifically for the functional neurosurgery.
Well, you know, Sean, I guess neurologists can do this too then, correct?
Well, you know, typically we respect healthy boundaries. You know, we think that as a team, it works best to have the neurosurgeons do the procedure itself, because neurosurgeons are experts in actually interacting with the brain tissue this way. And neurologists typically will do the diagnosis and programming of the devices and the follow-up. But, you know, to be honest with you, I do see that there's a blurring of the lines taking place. I had the great fortune of visiting University of Texas at Houston last week, and met with Dr. Choi, who's actually one of the neurointensive care neurologists over there, and he works under Dr. Lee. Ki-Wan Lee is one of the great neurocritical care docs. And in their department, it really is a hybrid of neurosurgery, neurology, and rehabilitation medicine, and nursing, and physical therapy. It's everybody's under one roof. And I think what you're going to see as time goes on, John, because you did touch on this a bit, is that ultimately outcomes are what are going to drive who does procedures. And the best outcomes, it seems, come when there's a strong team approach, and it's interdisciplinary and focused on the whole patient. You know, stereotactic procedures, they're not meant for, you know, the small rural hospital with one person out there doing the procedures. You know, it does require a significant devotion of resources at the institutional level, and a lot of data, you know, data tracking, data mining, and a team approach. And in most centers that do stereotactic surgery, you'll find that the same kind of approach is not too different from what you'd see with oncology, where there's a tumor board, and periodically they meet and discuss cases and, you know, review their outcomes and such. So while technically speaking, you're right, I mean, we may see one day when doctors aren't even involved in these processes, that there's so much precision and automation that you can go to, you know, stereotactic brain surgery R Us and drive through and get your brain zapped. But I think we're a long way from that still. So.
Well, you know, I'm sure there's so many questions. Does anybody have questions they want to ask Sean?
Just John, hello.
Yeah, go ahead, Suri.
Yeah, just I want to give some additional points regarding the Parkinsonism surgery, because in the brief, basically, Sheen did very nice presentation. I want to thank, because it is a sudden presentation and wonderful presentation. It is a very difficult task to do on the time without any preparation. He did very nice, and everything he covered. But in the brief, basically, as a neurosurgeon, I want to add that preoperative diagnosis of correct Parkinsonism disorder, Parkinsonism, is a success of the key success of the surgery. Correct diagnosis with the criteria which used to fulfill the approach for the surgeon, and we have to fulfill the point. These are the basic concept or basic success of Parkinson's surgery. Basically, surgery or navigation via the navigation or lesioning or deep brain stimulation is not a very big deal with the higher technology. But the diagnosis by the neurologist, what they're doing in the OPD or in the ward side, is a 80% of the dedication. That is the 80% part of the success of the surgery. So pre-operative diagnosis is a main concept, main theme of the total stereotactic surgery of the Parkinsonism. Intraoperative complications like hematoma or post-operative, immediate post-operative infections like meningitis are a little bit common, because it's a like minimal invasive type surgery, which is most of the time blind and depend on the navigation system. And post-operatively, there may be failure of the surgery, or there may be late complications like optic nerve damage, or there may be after long term that electrode can give some problem with the optic chiasma, or because STN and globus pallidus is very near to the optic nerve and chiasma. So that all complications should be evaluated by the neurologist post-operatively, because neurosurgeon will not available because of his hectic work schedule, or he's in OT, operation theater, and like that. So I want to tell, and I want to give thanks to Sheen, because he is a neurologist and he is a main hero, and his team is a main hero for the Parkinsonism, because surgeon is only used to do electrode placing or lesioning and all. But preoperative and postoperative care is a 90% success of the Parkinsonism surgery. Thank you.
Okay, yeah, we're having some audio issues, but we'll improve on that. Now, this is a general question for Sean or Suri. I did a little bit of reading on this, and the patient is actually awake, Sean, during this procedure, so that you can get feedback of where you're at as far as placement. How does that work?
Yeah, John, generally speaking, these... Go ahead, Suri.
Yeah, Shink, go ahead.
The patient is awake during the procedure?
Yeah, John. The patients are awake, and that's actually the benefit of this kind of procedure. Again, whether there is whether it's done through a craniotomy or if it's done non-invasively, either way you do it, the patients ought to be awake. And this accomplishes two things. Number one, it helps you to detect if you're going to have a complication, the patient has a sudden neurological change for the worse, then you know immediately. You don't have to wait until after the patient wakens from anesthesia to find out. Number two, when you're actually placing, if you're doing, let's say, a deep brain stimulator, if you're placing the leads, we'll actually turn on the device intraoperatively, and we'll ask the patient to go through a series of steps that we assess while they're getting stimulated. And so we can actually see a patient who's on the table with a significant tremor, and then you turn on the pacemaker, and the tremor stops and slows and stops. So it's an immediate effect for many of these patients. It's quite dramatic, actually. And,
well, I found that very fascinating, Sean, and Simon and Eleonora and Dustin. That's to be awake during a major surgery almost. It's a fascinating concept, and it makes sense, really. If it can work, it's very valuable to get that immediate feedback. I can't recall of any areas of surgery where that's done.
Well, actually, honestly, in the neurological realm, when it comes to endovascular rescue for acute strokes, this is another area where we'll keep the patients awake. So let's say a patient comes in with acute ischemic cerebral infarction involving the left middle cerebral artery territory, for example. So this is a patient that may present with flaccid paralysis on the right-hand side and a complete loss of speech abilities. If we diagnose them with acute stroke, we may actually send them into a cath lab or a special procedures laboratory with a fluoroscopy device, and we use miniature balloons and other kinds of tools, what we call embolectomy devices, to snag the clot out of the artery and restore blood flow to the affected side of the brain. And it's very gratifying to take a patient on the table who's awake, unable to talk, and you restore blood flow, and on the table they can start to talk to you and move their right side again. Well, it's pretty dramatic.
That's incredible. Yeah. So you can see the change now in that area of neurology nowadays?
That is the change. I can tell you, whenever I trained back in the late 1990s in this area, the dominant style was to anesthetize patients with brain injury for the most part, and then do the procedure relying upon the radiological images to guide us, and then when they're done with anesthesia, hopefully they would wake up better. But there is no better monitor for the brain than the brain itself and the behavior of the patient on the table. And so we typically really rely upon their function, and that has been a sea change in neurology, John.
Yeah, it's neurology. One of the things that I've gleaned, well, I've been having hangouts with a neurologist from Toronto, Dr. Rana. I don't know if you know him, but one of the things I was impressed with, and I'm sure you've probably seen this, is that neurologists have to be at the top of the game when you take a history and physical. It's not, you don't just walk into the room and just order a test. It's like, wow, you're going to take a pretty detailed history and do a detailed physical exam, probably more than most specialties.
That's a very good point, John, and I think, as it applies to this particular talk today with stereotactic therapy, I think, Surya made a very good point, and that is that first and foremost, you have to make a diagnosis of idiopathic Parkinson disease. If you want to have a successful outcome, you have to give the patient what the patient needs, no more, no less. You have to be highly precise. and a greatly detailed examination and history. Honestly, history is absolutely critical with these folks. There are some other things too. I mean, a positive response to levodopa therapy is important, and that's part of the history. Generally speaking, as much as we can, normal cognition and an absence of any active psychiatric disease is important as well. So a patient who presents with what appears to be Parkinson disease, but maybe also has elements of schizophrenia, for example, which sometimes you only get after a really detailed history. It can be tough sometimes. Some folks have a fixed delusion, for example, maybe that they think that the world is run by pigs, or that the moon is made of ice cream. You know, those are maybe patients that you might not think about stereotactic therapy. And also just assessing the patient's support system and what kind of access that they have to ongoing treatment. Those are all very important parts of the history. And so you're right, this is something that's hard to automate. There's a lot of nuance and intuition that's involved. And again, one day maybe those will all be replaced by automated solutions. Maybe IBM will come up with the next best neurologist in a box. But at least in today's environment, it does take a lot of detailed questioning to be able to come up with good diagnosis and improve outcomes. It's all about good outcomes.
Okay, I'm sure Simon and Eleonora, do you have questions?
If I may, oh sorry, Eleonora first.
You can go first. Okay, thank you. Yeah, I agree with the fact that the history is the most important part in the neurologist's work. Dr. Orr, thank you for the precise presentation. I have a question. I would like to know if we already have some precise indications for the stereotactic therapy. I mean, it depends on patients, or do we have some indications, for example, idiopathic Parkinsonism and something more?
Well, I mean, the indication is idiopathic Parkinson disease. So we would not be using the stereotactic techniques that we're talking about today in somebody that has one of the other autonomic Parkinson, like Shy-Drager syndrome, for example. We would not use it for a patient who has normal pressure hydrocephalus. We would use a different surgical approach for that kind of patient. That patient would actually probably get a shunt, a ventricular peritoneal or lumboperitoneal shunt. So again, precision is really the name of the game here. And so in order to be precise, we have to have a high degree of certainty that we're dealing with a condition that responds to the therapy.
Right.
And like as you mentioned, most centers don't have the equipment, right? It's so expensive. It's just the big hospitals in the big cities have it.
Yeah, typically it's a larger center, usually an academic center or a another center that's maybe not academic but has really very strong neurosciences.
And a lot of bucks.
You can look. Right.
Simon, you have a question?
Yes, please. Firstly, regarding the history, how long would it take to take a history? And in the case where there is a Parkinson syndrome and it is normal pressure hydrocephalus, how would you measure this in the brain, the normal pressure hydrocephalus?
Well, that's a great question, and there are so many variables there, Simon. To take a history, it kind of depends on the maturity of the doctor involved. And I can tell you that when I was a resident, if I was interviewing a patient, I might take an hour and a half. And I was pretty inefficient, and I also hadn't built in my experience, right, the intuition. Now, when I'm taking a history of a patient. And again, it depends on the patient, but sometimes sometimes you can see walking in the door, honestly, you can make the diagnosis. And in fact, it's one of those funny phenomena of a seasoned neurologist. Now, when I go to the mall with my family, I can almost spot people and their neurological syndromes. It's a bit of a curse after a while. But for the part, to be precise, it does require still detailed questioning. It's not something that you want to take lightly. And so you will ask other salient questions, such as, if you stand up rapidly, do you get very dizzy? which might be a sign of autonomic failure. Have you had advanced constipation, or do you have incontinence? Could be other signs or palpitations. There are a variety of questions that we ask around the autonomic questions and it gets tricky because people with idiopathic Parkinson disease can have autonomic failure that's not due to the kind of changes that we see with Shy-Drager syndrome. There's another Parkinsonian syndrome that involves the deposition of material throughout the brain that is much like what we would see with Alzheimer's disease, and so again, you can get changes that are Parkinsonian, but also significant neuropsychiatric changes like hallucinations, for example. And so, we sometimes, if we're on the borderline between those two, we'll use other imaging studies. It turns out that with MRI or with PET scan, we can actually construct images that help us to become much more precise with our diagnosis. So I include those in my workup. And so when you're talking about how long to do a history, sometimes I may see a patient numerous times before we finally conclude their type of Parkinson. And then to answer your question about the normal pressure hydrocephalus, this is something that is near and dear to my heart. I've been a bit on the warpath about this condition because I'm very motivated by the fact that the data would show that there are probably hundreds of thousands of patients who have been misdiagnosed with Alzheimer's disease in nursing homes who actually have normal pressure hydrocephalus.
Really?
And because so many people are affected by this, we don't have that many neurologists, and primary care doctors do what they can, but still a lot of folks end up slipping through the cracks. And so at the end of the day, if somebody's very advanced with their normal pressure hydrocephalus, maybe it really doesn't make a difference. But by the time somebody gets to the point where they're demented and they have chronic severe urinary incontinence, at that point maybe surgery really is just not going to make a difference for them. But early on, it can make a significant difference. And so with those patients, what we'll typically do is if they come in with those classic findings, dementia, so cognitive loss, which typically presents as an anterior frontal dementia, they'll typically get a difficulty walking, which we've traditionally called gait apraxia. Generally, it's almost a forgetting or a loss of fluidity, and these folks will actually appears that they're stuck to the ground with magnets. They just forget how to lift their legs and move their feet, so they'll often fall. These patients will at times present to the emergency room with falls. That's the hallmark findings, that they'll break a bone or smash their head because they've fallen. And then urinary incontinence is the third part of that triad. And the reason for that is that as the pressure builds up in the brain, one of the first areas to start to fail is what we call the micturition centers, and the anterior frontal region and the lateral prefrontal cortex. So the micturition centers control the bladder, and as the pressure builds up from hydrocephalus, those fail early on. Early in the course of the disease, these patients will be too embarrassed to talk about it, but sometimes you'll see they'll come in with stained pants and family members that don't want to even discuss it. So it can be a big relief to them when you start to talk about it. Now, the diagnosis typically is made on clinical grounds, but to be more precise, imaging is helpful. On MRI imaging, there are some characteristic hallmark findings. Not only do the ventricular chambers of the brain appear to enlarge, but the sulci of the brain actually develop a bulbous enlargement that's fairly characteristic and different from the kind of sulcal enlargement that you would see with brain atrophy, like in Alzheimer's disease. So that's one of the subtle nuances that is not always appreciated, but can be helpful in making the diagnosis. There are some other characteristic nuanced changes. And then highly sophisticated centers such as Columbia University in New York, for example, their chairman of neurosurgery, their chairman emeritus, put this on the map, but long-term monitoring of the intracranial pressure can be very helpful. And that's because, and this is where the name came from, normal pressure hydrocephalus, you would think somebody with a buildup of fluid in the brain would have a high pressure. With normal pressure hydrocephalus, they don't always, and there can be fluctuations over time. As the pressure builds up in the brain, patients will decompensate, and then finally when the pressure gets high enough, it will actually blow open the drainage passageways and the pressure will be relieved for a while. So if you're just spot checking the pressure with a spinal tap, for example, you may be not lucky enough to actually catch that pressure elevation. So some patients will have long-term lumbar drains or even ventricular drains placed to monitor them, sometimes 3, 4, 5, 7 days in an intensive care setting, and the pressures will be tracked over time and correlated with behavioral changes. And so if you do make the diagnosis that way, it can be very useful, and you can even do some testing to see how they'll respond to removal of cerebrospinal fluid. Many doctors will just go ahead and place a shunt if they suspect it. And the ventricular peritoneal shunt drains the fluid from the brain to the abdomen. And nowadays we actually have adjustable shunts that, like the pacemaker, can be adjusted with a magnet, and we can actually open a small screw underneath the scalp using the magnet, and that can allow us to drain more fluid or less so that we don't drain the chambers of the brain too fast. So this is actually technically probably should be included in the stereotactic surgeries because it does require placing a shunt into the brain. Although arguably, when a patient has hydrocephalus, it's pretty hard to miss the ventricles because they're so large. So it doesn't have quite the same demand for precision that idiopathic Parkinson disease surgery has. So.
Okay, sorry.
Oh yeah.
Go ahead.
I was wondering how young what is the youngest you might see actual Parkinson's diagnosis?
For idiopathic Parkinson, I can tell you I've taken care of patients who have been diagnosed in their 30s.
Wow.
I'm actually taking care of a doctor right now I just saw for the first time last week who has idiopathic Parkinson disease, and he's very well controlled on his medications. He's, I think, just turned 40.
Wow.
And he's had it for a few years. So.
How was that picked up? How was his Parkinsonism picked up?
He, not to put him at risk, but he did a kind of medicine that made it obvious when he was performing procedures that he had a tremor. And he's had to stop performing procedures. And then he developed the classic masked faces, so kind of a non-changing facial expression, and his gait changed as well. And being a doctor, I think he picked up on it pretty quickly. So he got diagnosed early and on therapy.
Okay.
I can tell you with normal pressure hydrocephalus, Simon, I've taken care of patients as young as their 40s also, and it turns out that there probably is a sizable group of patients, and we don't know how many, but a sizable group of patients with normal pressure hydrocephalus who actually start to develop it in their 40s. And they have such a mild case of it that they compensate, and it's not until they're in their 60s or even 70s where it's finally obvious enough that you can't ignore it anymore. But if you have a very astute patient who has Parkinsonian symptoms and you have an astute neurologist who picks it up carefully or early on, there's this kind of an early onset normal pressure hydrocephalus that has been characterized in the literature and does respond to treatment. So, generally speaking, those are taken care of in high-level academic centers around the country. So.
Okay, Suri, do you have any comments? Suri, can you hear me? Okay.
Yeah. For Simon, hi Simon.
Hello.
Yeah, some points are there. Actually, you are asking about the diagnosis of the normal pressure hydrocephalus.
Yes.
Flow MRI is one of the best diagnosis. Flow MRI. So CSF flow MRI is there. We can do like that because Parkinsonism and normal pressure hydrocephalus, we can do differentiate between the flow MRI. CSF flow MRI will be the significantly positive we can use to get daily life in normal pressure hydrocephalus. Second thing is that we can see the optic nerve cage, optic nerve sheath. We can see there also. That is also a significantly positive in the normal pressure hydrocephalus, which is not commonly in the classical type of Parkinsonism patients. Like that, we can differentiate and specifically gait disturbances, dementia, and the urinary incontinence is a classical triad of the normal pressure hydrocephalus, which is generally means I saw in my till date, I saw near about 70% patients of the normal pressure hydrocephalus we are getting this triad. So by this way, classifications of the normal hydrocephalus. So we can use that classification for the approaches. Diagnostic purpose, we can see the CSF flow MRI, and we can see the before that our neurologist told that we can see other investigations. Also, already told, but I want to add that CSF flow MRI, we can differentiate between the Parkinsonism and the NPH, and the optic sheath pressure also we can differentiate between the classical Parkinsonism and the NPH. Second thing for this, yeah.
Thank you very much. Oh, I see. Yes, yes.
Yeah. Second, for the clinical approaches, like, for clinical examination for the classical Parkinsonism, also like a big long history, and for the NPH, that is most commonly 30 to 40 year of the age, because in India specifically, like we are working in the Indian ground, and as per the literature, postpartum women are more commonly presenting with the NPH. Postpartum, that age is like 30 to 40 in the female. Female is more prone, which is postpartum, and age between the 30 to 40. So most commonly Parkinsonism we can differentiate on this ground, and we can't confuse, and we can send the patient for the surgery also.
Wow, thank you very much.
Yeah.
Okay.
Yeah.
Go ahead. Go ahead.
Yeah. See, I want to discuss some special point Parkinsonism. Like India, we are doing one research on the Parkinsonism treatment with the stem cell therapy. Are you interested in stem cell therapy for the Parkinsonism? Dopaminergic cells we are putting, and we are doing some research work. I did in that research 24 cases, and still I'm waiting for.
I think it's fascinating, and I am very interested in it. I think that's actually the wave of the future. I had the great fortune of being at the University of South Florida in Tampa when the very first reports came out of dopaminergic neurons, actually come from Sertoli cells in the testicles, were used to actually create dopaminergic neurons. And then also the fetal cell transplants, which of course has been very ethically controversial, especially in the United States. But I do think that now that stem cell therapeutic has evolved to the point where we can create stem cells from skin, that really changes the whole ethical discussion at this point. So yeah, I think that is truly one of the ways of the future. That, and then neuroprotective therapy, and I think nanotechnology is also going to have a big role to play there too.
What centers is that research going on, Sean, in Parkinsonism? Stem cell therapy and Parkinsonism. You mentioned Texas.
So to be honest, I'm not sure in Texas. I'm sure there's a place in Texas that's working on it, probably Baylor. Okay. I can tell you from my personal experience, University of South Florida in Tampa is considered one of the leaders. We actually have Juan Sanchez Ramos, who has been one of the earliest stem cell researchers in Parkinson. He's very famous for what he's done. He also has done a lot of work on Huntington disease and identifying the pathophysiology of Huntington, which is another, kind of Parkinsonian mimicker. And he's working on stem cell therapeutics for that. University of Florida in Gainesville has actually distinguished themselves. They have a very strong program. I would say Scripps Institute in La Jolla has a 100,000 square foot, size space that they're working on stem cell therapeutics, and they've distinguished themselves, and I believe that they have a branch over here in Florida as well. I can tell you that Mount Sinai in New York, which is the Icahn School of Medicine, they have a fairly vigorous stem cell program, and I'm sure there are more that are just not occurring to me off the top of my head, but it is now that we're past the 1990s and 2000s. There is a interest in therapeutics in the United States, and the dam has burst. So my prediction is that within the next 5 years, you're going to see a very large number of indications and applications come online that legitimize stem cell therapeutics, especially now that the ethical implications have been, dealt with through advanced technologies.
Yeah, to me, there's no other area in medicine that needs more education. I'm like most physicians. I really don't know much at all about stem cell, research and what the issues involved. And I don't know if now in medical school they teach. Do they teach you guys that now, Eleonora and Simon, stem cells a little bit in medical school?
Yes, they do.
They do. They didn't teach us anything. I don't know, Sean, you got any, and Shuri, if you got any teaching, but I don't recall any teaching at all. When I went to school a long time ago. But certainly there's lots. Go ahead. Go ahead.
I think that we knew that there were stem cells. When I was going through medical school, it was
that's about it.
Hey, we've identified. It was like the Holy Grail.
Yeah,
we actually found that they existed.
That was about it.
Yeah.
Any more questions before we wrap it up? Any more comments? Oh, well, one question. Go ahead. Go ahead.
See, what is your comment about the PPN? It's a new nucleus. We are working on that pre-pontine nucleus for the Parkinsonism. Is there any points?
I've read about it. I have read about it. I haven't had personal experience with the pre-pontine nucleus. I mean, from a mechanical standpoint, it makes sense that that it might be involved in Parkinson's, and that therapy may be useful. I would say it's from a practical standpoint, getting to it is challenging. But the technology is advancing, and so have you had experience yourself, Surya, with ablation of the PPN?
Yeah, actually we did in 2 patients. We tried for that PPN by the permission of Medical Council of India. But there is no. It's like as per the literature, they are giving some more importance. But as per the work in the 2 patients, we are not getting that much difference. ST and PPN is near about. We are getting same type of results. But it's not a very big number of patients. Only 2 patients we did. So now in future we can say more about this.
It's interesting that you bring it up, because what I'm seeing is this trend towards, earlier therapy. I mean, if you look at what we were doing 10 or 15 years ago, we would only wait until somebody was fairly advanced in their disease to use stereotactic therapy. And now I see that there's a general acceptance that it's okay to do it earlier, and I think we're maybe even starting to transition to the idea that it's actually beneficial to intervene earlier, because you can possibly alter the course of the disease in a favorable fashion. So from that point of view, I think when you consider that one of the very first earliest signs of Parkinson's disease, idiopathic Parkinson's disease, is dysphagia, then the pre-pontine nucleus starts to become a little bit more of an appealing target because of its impact on the swallowing reflex and its involvement with other brainstem functions. So from that point of view, we might find that maybe patients segregate out into different categories. Maybe patients with early dysphagia and aspiration pneumonia as a presenting sign might benefit from more aggressive therapy at the pre-pontine nucleus. That's just, I'm supposing off the top of my head, but you can kind of imagine that things might go in that direction.
Well, I was going to ask you that, Sean. Is that because the concept of imprinting is more believable, that a neural pathway, and that's one of the things I picked up on when you were talking about early intervention. Is that because neural pathways will imprint on a pathological thing like tremor? It'll be too late to reverse if you don't intervene quickly?
Well, you're kind of getting at the idea of neuroplasticity there, John. And, I think, I don't know if anybody has demonstrated yet that plasticity itself is involved in the tremor. If you take the condition of chronic pain, for example, we do know that, if somebody has, let's say, chronic regional pain syndrome type 2, which we used to call reflex sympathetic dystrophy, they really, their source of pain is gone, but they have pathologically imprinted or invoked neuroplasticity to augment pain signals to the brain in a pathological fashion. So in those folks, our work is all about trying to reduce the effect of these pathological changes, because after all, neurons that fire together wire together, right? Mm-hmm. Ramon y Cajal, who was one of the earliest neurologists, used to say that the brain is fixed and immutable and unchangeable, but we know now that that is not the case, that neuronal pathways are highly modifiable and can grow healthfully or sometimes in a pathological fashion together. So, but as it pertains to tremor, I think the going thinking right now, and again, I could be wrong, but I think the going thinking is that since we're dealing with a neurodegenerative disease, as tremor progresses, if you think about tremor, it's an ongoing movement. So you've got the natural pacemaker cycle of the brain that's constantly firing in the background. if that pacemaker is uncontrolled and those neurons are working more than normal, they can burn out. And so the tremor can worsen naturally on its own more rapidly because the degenerative process is facilitated by this constant unrelenting clock that's ticking away. And so really we think that degenerative effect is what it begets itself. Dr. Stan Fahn, who's one of the luminary neurologists in the movement disorder arena, first put forth this idea that there's kind of an oxidative degenerative process taking place in these dopamine-rich neurons that are very rich in iron, and that by interrupting the tremor early on, you might have a protective effect against further damage down the road. But I think that's still a fairly controversial topic.
Okay.
We'll probably know more in 10 years.
Okay. Okay. Any more questions or comments before we wrap it up? Okay. Well, Sean, thank you very much for pinch hitting. You did a great job. And
Thank you very much.
I'm sure we could go on all afternoon. There's many fascinating things you brought up, and I think we'll all agree it was very educational. And thank you, Suri, for coming.
Thanks.
And we'll call this an end to this hangout on neurosurgical.tv. And we'll see you next time.